Normal 2D views of the aorta were discussed on tape number 1 of this series. We would like to review these now before proceeding with the discussion of aortic diseases. From upper left peristernal positions, the aortic sinuses and the proximal ascending aorta can be imaged. As the aorta dilates with various disease processes, right peristernal transducer positions can also be used to inspect this portion of the aorta. The arch is imaged from the suprasternal notch. The ascending and descending aorta can also be investigated from right and left supraclavicular positions. The descending thoracic aorta can be visualized behind the left atrium using a left peristernal approach. The abdominal aorta and its branches can be fully visualized using subcostal transducer positions. Remember that patients with left pleural effusions present an additional ultrasonic window for visualization of the descending thoracic aorta. Recognizing this large left pleural effusion, we have placed the transducer near the patient's left scapula. Since the fluid is an excellent conductor of ultrasound, the descending thoracic aorta is clearly imaged. This is a fibrin clump within the pleural fluid. The diseases of the aorta which we will illustrate include annulo-aortic ectasia, sinus of Valsalva aneurysm, atherosclerotic aneurysms, aortic mycotic aneurysms, pseudoaneurysms, and aortic dissection. Annulo-aortic ectasia is a relatively common condition which results in generalized dilatation of the sinuses of Valsalva and the ascending aorta. The junction between the sinuses and the tubular portion of the aorta is typically effaced. The underlying pathology is cystic medial necrosis. Although a subset of these patients have Marfan syndrome, there are a large number of patients with annulo-aortic ectasia who will have no clinical features for Marfan's. This is the standard peristernal long axis view. The sinuses of Valsalva are enlarged. A very limited portion of the aortic root is displayed on this view. The aortic valve cusps appear normal. By moving the transducer one interspace higher, we are able to clearly visualize the aorta for several centimeters. The root is ectatic. Note the effacement of the sino-tubular junction. In short axis, mild enlargement of all three sinuses is evident. Any process which enlarges the aortic sinuses and annulus can result in aortic regurgitation. Returning to peristernal long axis format, we see that this patient has moderate aortic regurgitation, secondary to his ectatic aortic root. Transesophageal echocardiography has rapidly become the method of choice for delineating diseases of the thoracic aorta, particularly in cases with suboptimal images from surface echo. The transducer is in the esophagus, behind the left atrium. The aortic sinuses are markedly enlarged. In this case, dilatation of the annulus has resulted in severe aortic regurgitation. This patient had clinical features typical of Marfan syndrome. The aortic sinuses are markedly enlarged. Compare this diameter to the diameter of the descending aorta. The mitral leaflets appear myxomatous. This patient has classic echocardiographic features of Marfan's, including not only the annulo-aortic ectasia, but also marked mitral valve prolapse. Here, we are viewing the enlarged sinuses in short axis. We will now scan to the aortic root above valve level. The diameter of the root is 6.5 centimeters. The ascending aorta is being imaged from the suprasternal position. The enlarged root is pear-shaped, tapering to a normal diameter at the level of the arch. Sinus of Valsalva aneurysm results from congenital weakening or absence of the media in one of the aortic sinuses. As in this case, the right coronary sinus is by far the most commonly involved. While intact, these aneurysms rarely cause symptoms. In short axis, this is the left atrium, and this is the right. The left and non-coronary aortic cusps appear normal. The large aneurysm of the right coronary sinus protrudes into the right ventricular outflow tract. When these rupture, an aorto-right ventricular shunt develops. Aneurysms of the non-coronary sinus are uncommon, and the left coronary sinus is rarely involved. You can appreciate that rupture of the non-coronary sinus would lead to communication with the right atrium. This patient had experienced sudden onset of dyspnea, and a new murmur had been discovered. This small, sac-like echo appears to be attached to the septal tricuspid leaflet, but is actually the windsock from a ruptured aneurysm of the right coronary sinus of Valsalva. The image has been expanded. This is the right ventricle, left atrium, and aortic root. This is the right coronary sinus. A real-time scan will demonstrate the close proximity of the windsock to the right coronary sinus and the septal tricuspid leaflet. Color flow imaging was technically difficult, but demonstrated a continuous shunt near the septal tricuspid leaflet into the right ventricle. A diagnosis of ruptured sinus of Valsalva aneurysm was made, and the patient was taken to surgery without catheterization. This is an intraoperative epicardial examination. This is the ruptured windsock, which has created communication between the right coronary sinus of Valsalva and the RVOT. This is a diastolic frame. The windsock is fully open. In systole, the right coronary cusp has opened against the wall of the sinus, and the windsock is largely collapsed. This explains the characteristic murmur of ruptured sinus of Valsalva aneurysm, continuous but with diastolic accentuation. In diastole, with the aortic cusps closed, this mosaic color map represents the shunt from aorta to RVOT. In systole, the shunt is greatly reduced. Following surgical repair, epicardial echo verifies that the right coronary sinus is intact. This is an example of a fusiform aneurysm of the thoracic aorta. There is marked atherosclerotic involvement of the entire aorta. This particular aneurysm begins just above the aortic valve and extends to the arch and descending thoracic aorta. There is thrombus in the descending aorta and also in the abdominal aorta. This suprasternal image is from a patient with an ischemic cardiomyopathy who presented with severe low output failure. In real time, you will see a Swan-Ganz catheter in the right pulmonary artery, which is here in short axis. This is the aortic root and arch. There is a large fusiform aneurysm involving the descending aorta. The lumen is narrowed by a large amount of thrombus. The aneurysm measures 7.5 centimeters in diameter. In real time, you will see a long, linear, mobile structure within the lumen. This is the left ventricle and mitral valve in short axis. The descending thoracic aorta appears in long axis and is aneurysmal. This is thrombus here and here. A linear echo is again seen within the lumen. This patient expired, and at autopsy, this linear structure was found to be a pseudomembrane that had formed over the surface of the thrombus within the fusiform aneurysm. These pseudomembranes can masquerade as intimal flaps and lead to an incorrect diagnosis of aortic dissection. The preceding study was performed in 1983. More recently, with the introduction of transesophageal echocardiography, aortic pathology is more readily and clearly identified. This is a transesophageal short-axis view of the descending aorta from a 70-year-old male. This crescentic density is thrombus, which is laminated over the surface of this thoracic aortic aneurysm. These smoke-like, swirling echoes reflect the very low flow rate through this aneurysmal segment of the aorta. The diameter of the aneurysm is 7 centimeters. This is a transesophageal image of the descending thoracic aorta. Since there are no landmarks within the descending aorta, it is important for the echocardiographer to document the level of each image by noting the centimeters, measured from the patient's incisors, that the probe has been advanced. This image was obtained at 20 centimeters and shows another accumulation of thrombus. It is critical to determine if this thrombus is layered over the intimal surface or if it is within the wall of the aorta. In real time, you saw a small, mobile thrombus within the lumen. The probe has now been advanced to 30 centimeters, and we identify even more worrisome pathology. Atherosclerotic plaque has been lifted, and blood has dissected beneath it, penetrating the wall of the aorta. This is adventitia. These penetrating aneurysms carry a high risk of complete rupture. A prompt surgical approach is generally indicated, particularly if associated with symptoms such as back pain. Flow imaging verifies that blood is penetrating through the intima into the wall of the aorta. As the scope was tilted slightly, higher velocity flow was noted here within the wall of the aorta. Echocardiography is also useful in the diagnosis of aortic pseudoaneurysms and mycotic aneurysms. This patient presented with a history of weight loss. On this parasternal long axis view, there is a thick-walled cystic structure adjacent to the aortic root. The cystic structure is also apparent on this short axis image at the level of the aortic valve. Color flow imaging confirmed communication between the aorta and the cyst, which at surgery was found to be a mycotic aneurysm due to histoplasmosis. Transesophageal echocardiography in this 78-year-old male identified this cavity adjacent to the aorta. This is a pseudoaneurysm which contains thrombus. There is significant risk of full aortic rupture through the adventitia which lines the false aneurysm. The image has been expanded. This is the false aneurysm, aortic root, and LVOT. In addition to the aortic regurgitation, color flow imaging demonstrates the communication between the aorta and the pseudoaneurysm. Aortic dissection is a life-threatening condition which has a large variety of clinical presentations. Accurate and prompt diagnosis is essential. We believe that echocardiography is the diagnostic modality of choice for most cases of aortic dissection. Dissection occurs in the setting of disease of the aortic media, most commonly cystic medial necrosis. Blood under pressure enters the media through an intimal tear and dissects its way through the media, both antegrade and retrograde. The intima, which forms the boundary between the true and false lumens, will appear as a linear flap within the aorta. Aortic dissections are classified according to their origin and extent. With type 1 dissections, the tear begins in the ascending aorta and extends into the arch and often beyond. The flap is limited to the ascending aorta with type 2 dissections. Both of these, which begin in the ascending aorta, are also referred to as proximal or type A dissections. Type 3 dissections begin beyond the left subclavian artery and therefore involve the descending aorta. These are also referred to as distal or type B dissections. This is a type 2 dissection. It is limited to the ascending aorta. This is the true lumen, this is the false lumen, and this is the intimal flap. There is thrombus within the false lumen, and the dissection has resulted in distortion of the aortic valve. This is a left parasternal long-axis view from a patient with Marfan syndrome. His aortic root is markedly enlarged. This is an intimal flap in the ascending aorta, which is diagnostic of type A dissection. This view was obtained with a transducer in a right parasternal position. With enlargement of the aortic root, this view becomes quite useful. This is the aortic valve, and this is the mitral. In real time, you will see that the intimal flap moves upward when the aortic valve opens. It is pushed by the blood ejected with systole. The suprasternal examination of this patient was technically difficult, but you can appreciate the huge aortic root, which tapers to normal caliber at the level of the descending aorta. This is the right pulmonary artery in short axis. A flap is evident within the arch, which means that this is a type 1 dissection. Transesophageal echo provides amazing clarity and confidence in identifying aortic pathology, including aortic dissection. However, this does not mean that surface echocardiography should be ignored when confronted with potential dissection. Surface echo is particularly useful in examination of the upper ascending aorta using the right peristernal approach. Although transesophageal echo visualizes the root and proximal ascending aorta, there's a short segment of upper ascending aorta that TEE is blinded to because of intervening trachea. This is a surface study from right peristernal. This is the aortic valve. A flap crosses the ascending aorta. This is a tear in the flap, which provides communication between true and false lumens. There is thrombus along the wall of the false lumen. This is a suprasternal view from the same patient. Markedly enlarged ascending aorta, arch, and descending aorta. The intimal flap extends through the ascending aorta and spirals into the arch. Surface echo is often able to identify flaps within the horizontal portion of the arch, which is seen here in short axis. This patient presented for echo because of aortic dilatation noted on chest x-ray 1 month after an episode of severe chest pain. In diastole, on this peristernal long axis view, intimal flap prolapses into the left ventricular outflow tract. This is the aortic arch from a suprasternal transducer position. An intimal flap crosses the horizontal portion of the arch. Surface echo is also well suited for identifying flap in the abdominal aorta. Using a subcostal transducer position, this thickened intimal flap was identified in the abdominal aorta. A cursor was guided across the abdominal aorta and the mobile flap is clearly evident on the M-mode tracing within the aorta. This patient underwent surgical repair of her type 1 dissection. The surgery was successfully performed immediately following the echocardiographic diagnosis without any additional procedures. Dr. Bijoy Kandiria reviewed our experience with surface echocardiography for the diagnosis of aortic dissection. In a retrospective analysis of 67 patients referred for echo to exclude aortic dissection, he found a sensitivity of 79% for 2D echo detection of intimal flap, which establishes the diagnosis of aortic dissection. The predictive accuracy of a positive 2D echo exam was 91%. Transesophageal echocardiography provides high-resolution images of the thoracic aorta. Since it can be performed rapidly at the bedside, it has become a mainstay for diagnosis of aortic dissection. This patient has a type 1 dissection, which was diagnosed via TEE. This is an intimal flap in the aortic root. In real time, you will see flail motion of the left coronary cusp. Flow imaging confirms severe aortic regurgitation. The transducer has been withdrawn to the level of the horizontal portion of the arch. Intimal flap traverses the arch. Finally, the transducer has been advanced and directed laterally to image the descending thoracic aorta. The flap extends to this level as well. Dr. Erbel and his colleagues, who participated in a European cooperative study, recently reported on the accuracy of transesophageal echo compared to computerized tomography and contrast angiography for 164 patients who were studied because of suspected dissection. In this group of patients, TEE was 99% sensitive, 98% specific, and had positive and negative predictive accuracies of 98% and 99% respectively. They noted that the diagnostic accuracy of TEE is at least as good as, if not slightly better than, contrast angiography. This is a transesophageal image of an intimal flap in the descending aorta of a 32-year-old female with type 1 dissection. Spontaneous contrast suggests that this is the false lumen. There appears to be an entry site here with communication between the true and false lumens. Color flow imaging confirms that this is the true lumen and identifies two entry sites from true to false lumen. Aortic dissection is a medical emergency because of the potential for death via severe aortic regurgitation, which has been previously illustrated. Death can also follow rupture through the adventitia with exsanguination, or rupture into the pericardial space with immediate tamponade. This latter is the most common mechanism of death with this disorder. For this reason, when aortic dissection is diagnosed, the echocardiographer should always look for pericardial effusion and evidence of tamponade. Aortic dissection can also cause death or severe compromise due to occlusion of major branch vessels, such as coronary or carotid. In conclusion, the combination of surface and transesophageal echocardiography with Doppler and color flow imaging provides the clinician with a powerful and versatile approach for patients with diseases of the aorta. Both surface and transesophageal echo can be completed at the bedside with immediate feedback of results. The comprehensive information that is provided by echocardiography usually allows a surgical decision without need for ancillary testing.